Hello, this is Major Peterson, and I am a Doctor of Nursing Practice resident at the Uniformed Services University, and I will be presenting on the topic of pharmacogenetic testing and treating major depressive disorder. This presentation will cover the purpose, a background related to pharmacogenetic testing and medication selection for behavioral health patients, followed by an overview of the cytochrome P450 family, catechol O methyltransferase, and methylene tetrahydrofolate reductase overview and testing information. I will then briefly discuss potential barriers to utilizing testing, and finally present a clinical pathway algorithm providing recommendations for decision-making of when to order genetic testing and which test to order. The purpose of this presentation is to increase awareness at the use of pharmacogenetic testing and the selection of antidepressant treatment for patients diagnosed with MDD is indicated within the DoD. Within the U.S., approximately 7% of the population over the age of 18 suffer from depression annually, and the rates of MDD are the highest amongst those aged between 18 and 25 years. During the period of 2009 through 2011, the U.S. Army had the highest rates of depression within the military and is roughly equal to the rate of depression within the U.S. as a whole. Use of antidepressant prescriptions can be imprecise and typically involve a high degree of trial and error. Choice of antidepressant is primarily based on the clinical presentation, patient lifestyle, and patient preferences. Providers usually prescribe antidepressants on an experimental basis and consideration of multiple factors, with subsequent changes to medications and doses based on inadequate therapeutic responses or side effects to the prescribed medications. Only around 1/3 of patients at 4 to 6 weeks will reach remission within the first trial of antidepressants in this trial and error prescribing model. An additional 4 to 6 weeks may be required to determine if increasing the dose of the selected antidepressant may yield more favorable symptom management. If the patient does not achieve adequate symptom response with a minimal side effect profile, another antidepressant may be trialed and the cycle repeats. Due to the potential risk for the service member to deteriorate, less than 3 months of stability from the last medication change will require frequent monitoring by the prescriber. During this period, the soldier is placed on a non-worldwide deployability status. Once the patient's symptoms are properly managed, then they may deploy with a medical waiver. In 2015, President Obama launched the Precision Care Initiative. The goal of the initiative is to promote the use of individual genetics, lifestyle, and the environment to provide evidence-based, patient-centered care. Precision medicine includes the use of pharmacogenetics, incorporating personal genetics and biomarkers and clinical medication prescription decisions. Pharmacogenetic testing can guide prescription decisions, resulting in higher rates of response and remission for depressed patients. Despite the potential positive outcomes of implementing the use of pharmacogenetics in psychiatric clinical practice, it is still an underutilized modality. One meta-analysis compared 3 prospective 2-arm studies, of which one of the studies was double-blinded and randomized, and the results of these studies demonstrated improved response by approximately 17% and increased remission rates of approximately 9% when pharmacogenetic testing was utilized in the selection of treatment for subjects with MDD. For active duty service members, improvements to response and remission from pharmacogenetic testing could result in an improved readiness rate, which ultimately could increase deployability. Widespread use of pharmacogenetic testing may remain underutilized until it becomes more common within civilian practice. There are many examples of the benefits of pharmacogenetic testing within the literature, but the most recent meta-analysis found in our literature review demonstrated higher rates of remission for patients diagnosed with MDD when pharmacogenetic testing was utilized in selection of the antidepressant treatment. For instance, this study, published approximately 8 months ago and authored by Boostman et al., examined 5 studies testing for the effectiveness in using pharmacogenetic testing and improved response and remission for patients with either depressive symptoms or major depressive disorder. In all 5 studies, remission equated to a Hamilton Depression Rating Scale 17 score of less than 7 within both the experimental group and the control group. When we examine the chart, all 5 of the studies demonstrated improvement, but the effect varied widely. There was wide difference in rates of remission between the pharmacogenetic guided sample, or the experimental group, and the unguided sample, or the control group. So in the Seen et al. Study, there was a difference of about 44% between the control group and the experimental group, where in the Perez et al. Study, there was only a difference of about 1%. Examining the more inclusive evidence table from our literature review, we can again appreciate that the results of each study listed identify that the use of pharmacogenetic testing and the selection of antidepressant treatment demonstrated improved symptom management or remission for patients with depressive symptoms or major depressive disorder. There was no clear evidence as to when it is optimal to order pharmacogenetic tests to improve or inform antidepressant treatment. There were, however, 2 themes that stood out as to when testing did occur, and that was at either presentation or baseline, and our failure to respond to current antidepressant therapy. Overall, the goal in the evidence was to mitigate the risk of potential prolonged failure to respond with repeated trials of antidepressants that may not be best given the patient's genetic profile. Now the presentation will highlight the potential benefits of the tests that are available to order for our patients through LabCorp, as well as what some of the results may look like. To include the CYP 450 family, COMT, and MTHFR. Beginning with a brief pharmacokinetic overview of the CYP 450 family. The CYP 450 enzymes make up the main enzyme family which catalyzes the oxidative biotransformation of nearly all medications. Of the over 100 functional genes and pseudogenes, less than 15 are responsible for the majority of drug metabolism and are categorized within the CYP1, CYP2, and CYP3 families. Many psychopharmacologic medications are metabolized by few or even one CYP enzyme. Normally, individuals inherit 2 wild-type alleles and are able to metabolize a medication at an anticipated rate. Some individuals, however, inherit a wild-type allele and a variant allele. The variant allele results in enzyme deficiency within the endoplasmic reticulum of hepatic cells and an inhibitory effect on oxidation of a medication dependent upon the presence of a specific cytochrome. Half dosages or medication change are commonly recommended for these patients with reduced metabolism. Conservative dosing is due to increased risk of potential side effects. Conversely, individuals who inherit multiple wild-type alleles have excessive levels of a specific cytochrome, increasing enzymatic synthesis and resulting in ultra-metabolizing of medications. So to summarize, 2 variant alleles results in slow liver metabolism of a medication, and 2 wild-type alleles result in the liver having higher rates of metabolism. CYP 452D6 enzyme has broad activity affecting the metabolism of approximately 20% of all medications, to include SSRIs, tricyclic antidepressants, SNRIs, NDRIs, SARIs, and beta blockers. The level of CYP 452D6 expressed in the liver varies considerably, and in certain livers there can be even a complete absence of function by the enzyme. Any deficient of function by CYP 452D6 enzyme will result in reduction of the metabolism of the medication. Reduced metabolism of the prescribed medication can affect efficacy in reducing depressive symptoms and achieving remission for patients with MDD. CYP 452D6 is the primary metabolizer of the following medications. CYP 450 2C19 enzyme is involved in the metabolism of both SSRIs, TCAs, and to a lesser extent SNRIs. Like CYP452D6, the level of CYP452C19 enzyme in the liver varies and may be completely absent. Non-functional CYP452C19 results in reduced metabolism of medications. CYP452C19 enzyme is the primary metabolizer of the listed medications. Half dosages or medication change are recommended for patients with reduced metabolism. Conservative dosing is due to increased risk of potential side effects, especially potential cardiac effects, associated with medications like citalopram or impiramine. Recently, the FDA provided new mandates in regards to the provision of laboratory test results. In response to the changes, LabCorp reports some of the CYP450 test results by function per allele. Typically, this is reported as a star and then a number. The NIH-funded Pharmacogenomics knowledge base website provides evidence-based drug recommendations based on allele function, which is available at the following website. COMT enzyme is chiefly located in the temporal cortical areas and the prefrontal cortex. The breakdown of catecholamines, such as dopamine, is the function of the COMT enzyme. The high level of activity by the COMT enzyme has shown to reduce DA levels within the PFC of patients with MDD and may also influence the amygdala. Those who have homozygous alleles have demonstrated, those who have homozygous alleles have demonstrated significantly decreased COMT genotype activity within the PFC and higher levels of dopamine when compared with VAL homozygous allele affected patients. Patients with the MET homozygous allele have increased dopamine levels within the PFC and have the potential for improved executive function. There is limited evidence that patients with the MET homozygous will have a more rapid response to SSRIs. Patients with the VAL homozygous allele have demonstrated dopamine levels within the PFC and have the potential for adaptation to stressful situations. MDD patients with the VAL homozygous allele have demonstrated decreased activity within the PFC. The COMT lab report from LabCorp typically lists the valine and methylene on line 1 of the report, which addresses the single nucleotide RS4680 polymorphism. LabCorp provides the codes G and A that correspond to amino acid 158, and the allele combinations are as follows. MTHFR is a rate-limiting enzyme in the folate pathway and has also been associated with reduced synthesis of neurotransmitters in MDD. There's some evidence indicating that supplemental L-methylfolate may lead to an improved response to some antidepressant medications by patients with MDD. The evidence supporting the use of supplemental L-methylfolate in patients with reduced MTHFR is mixed. Recent studies both support and dismissed the effectiveness of using L-methylfolate as an augmenting agent for antidepressants. LabCorp reports MTHFR is either being positive for or negative for the mutation C677T or A1298C, noting either presence of 2 single or 2 mutations. Some of the barriers associated with the ordering of pharmacogenetic testing include a correlation between the provider's level of knowledge related to current guidelines of pharmacogenetics and their comfort level with test ordering and counseling patients on the test outcomes. Additional barriers to test ordering can include the perceived cost of testing, prescribers' knowledge of when to order the tests, and where the samples should be sent. When the cost of pharmacogenetic testing can vary between companies, the costs associated with changing from one generic SSRI to another generic SSRI average to over $1,100 for the costs associated with medication management as well as the prescription. Please see the pharmacogenetic clinical pathway algorithm depicting the tests discussed in this presentation and when the results may indicate evidence-based antidepressant treatment choices and our L-methylfolate supplementation. Please note that this algorithm, as well as the slides from this presentation, are available as a separate PDF document on the educational link provided to you earlier. In conclusion, the use of pharmacogenetic testing and the selection of antidepressant treatment for patients diagnosed with MDD is indicated within the DoD. Psychiatric prescribers can know when and how to order pharmacogenetic testing for their patients diagnosed with MDD by using the clinical pathway algorithm, lab ordering, instructional videos, and this pharmacogenetic testing presentation. Also, as stated earlier, please remember that all of the educational materials to include this presentation are available through the following link. Thank you so much for your time and interest in this presentation.